Let us read about pulmonary embolism. Pulmonary embolism refers to the obstruction of the pulmonary artery or one of its branches by a thrombus or thrombi that originates somewhere in the venous system or in the right side of the heart. Most commonly, PE is due to the blood clot or thrombus. However, there are other types of emboli: air, fat, amniotic fluid, and septic from bacterial invasion of the thrombus. It is estimated that more than 500,000 of people develop PE yearly, resulting in more than 50,000 deaths. PE is a common disorder and often is associated with trauma, surgery, orthopedic, major abdominal surgery, pelvic and gynecologic surgeries. Pregnancy, heart failure, age older than 50 years, hypercoagulable states, and prolonged immobility. It may also occur in an apparently healthy person. Although most thrombi originate in the deep veins of the legs, other sites include the pelvic veins and the right atrium of the heart. A venous thrombosis can result from slowing of blood flow, that is stasis, secondary to damage to the blood vessel wall, particularly the endothelial lining, or changes in the blood coagulation mechanism. Atrial fibrillation is also a cause of pulmonary embolism. An enlarged right atrium in fibrillation causes blood to stagnate and form clots in this area. These clots are prone to travel into the pulmonary circulation. Pathophysiology. When a thrombus completely or partially obstructs a pulmonary artery or its branches, the alveolar dead space is increased. The area, although continuing to be ventilated, receives little or no blood flow. Thus, gas exchange is impaired or absent in this area. In addition, various substances are released from the clot and surrounding area, causing regional blood vessels and bronchioles to constrict. This causes an increase in pulmonary vascular resistance. This reaction compounds the ventilation perfusion imbalance. The hemodynamic consequences are increased pulmonary vascular resistance from the regional vasoconstriction and the reduced size of the pulmonary vascular bed. This results in an increase in pulmonary arterial pressure and in turn an increase in right ventricular work to maintain pulmonary blood flow. When the work requirements of the right ventricle exceeds its capacity, right ventricular failure occurs, leading to a decrease in cardiac output followed by a decrease in systemic blood pressure and in development of shock. Clinical manifestations. The symptoms of PE depend on the size of the thrombus. First one is dyspnea, tachypnea, that is very rapid respiratory rate, chest pain, usually sudden and pleuritic, anxiety, fever, tachycardia, apprehension, cough, diaphoresis, hemoptysis, and syncope. Sudden substernal pain, rapid and weak pulse, shock, syncope, and sudden death. The disease causes few signs and symptoms, whereas in other instances it mimics various other cardiopulmonary disorders. The clinical picture may mimic that of bronchopneumonia or heart failure. Assessment and diagnostic findings. Death from PE commonly occurs within 1 hour of symptoms, thus early recognition and diagnosis are priorities. Ventilation perfusion scan, pulmonary angiography, chest X-ray, ECG, peripheral vascular studies, impedance plethysmography, and arterial blood gas analysis. Plethysmography, plethysmography, plethysmography. The chest X-ray is usually normal but may show infiltrates, atelectasis, elevation of the diaphragm on the affected side, or the pleural effusion. The chest X-ray is most helpful in excluding other possible causes. ECG usually shows sinus tachycardia, PR interval depression, and non-specific T-wave changes. A ventilation perfusion scan is this test of choice in patients with suspected PE. The perfusion portion of the scan may indicate areas of diminished or absent blood flow and is the most useful test to rule out clinically important PE. A ventilation scan may show whether there is also a ventilation abnormality present. A normal perfusion scan rules out the diagnosis of PE. If there is a ventilation perfusion mismatch, the probability of PE is high. Spiral CT scan also CT of the chest may also assist in diagnosis. If lung scan results are not definite, pulmonary angiography considered as the gold standard for diagnosis of PE. The test is invasive and is performed in the interventional radiology department. A contrasting agent is injected into the pulmonary arterial system, allowing visualization of obstructions to blood flow and abnormalities. Prevention. To prevent deep vein thrombosis, active leg exercise to avoid venous stasis, early ambulation, use of elastic compression stockings and other general preventive measures. Patients who are undergoing major elective abdominal or thoracic surgery may receive anticoagulant therapy. Low doses of heparin may be given before surgery to reduce the risk of postoperative deep vein thrombosis and PE. Heparin should be administered subcutaneously 2 hours before surgery and continued every 8 to 12 hours until the patient is discharged. Patients who are older than 40 whose hemostasis is adequate elastic compression stockings can be used. The intermittent pneumatic leg compression device is also useful in preventing thromboembolism. Medical management. There are a variety of modalities. One is general measures to improve respiratory and vascular status, anticoagulation therapy, thrombolytic therapy, surgical intervention. Emergency management. Nasal oxygen is administered immediately to relieve by hypoxemia, respiratory distress and central cyanosis. Second one, intravenous infusion lines are started to establish routes for medications or fluids that will be needed. Third, a perfusion scan, hemodynamics measurements and arterial blood gas determinants are performed. Spiral CT or pulmonary angiography may be performed. Fourth one, hypotension is treated by slow infusion of dobutamine or dopamine. The ECG is monitored continuously for dysarrhythmias and right ventricular failure which may occur suddenly. Digitalis glycosides, intravenous diuretics and antiarrhythmic agents are administered when appropriate. Blood is drawn from serum electrolytes, complete blood count and hematocrit. If clinical assessment and arterial blood gas analysis indicate the need, the patient is intubated and placed on the mechanical ventilator. Indwelling urinary catheter is inserted to monitor urinary output. Small doses of intravenous morphine and sedatives are administered to relieve the patient's anxiety, to alleviate chest discomfort, to improve tolerance of the endotracheal tube, and to ease the adaptation to the mechanical ventilator. Second one, general management, oxygen therapy to correct the hypoxemia using elastic compression stockings or intermittent pneumatic leg compression device reduces venous disease. Elevating the leg above the level of the heart also increases venous flow. Pharmacologic therapy, anticoagulation therapy. Heparin is used to prevent recurrence of emboli but has no effect on emboli that are already present. It is administered as the intravenous bolus of 5,000 to 10,000 units followed by a continuous infusion initiated at the dose of 18 unit per kg per hour, not to exceed 1600 unit per hour in otherwise healthy patients. The rate is reduced in patients with a high risk of bleeding. The goal is to keep the partial thromboplastin time 1.5 to 2.5 times normal. Warfarin sodium coumadin administered is begun within 24 hours after the start of heparin therapy because its onset of action is 4 to 5 days. Warfarin is usually continued for 3 to 6 months. The prothrombin time is maintained at 1.5 to 2.5 times normal. The INR international normalized ratio is of 2 to 3. Thrombolytic therapy. Thrombolytic therapy, urokinase, streptokinase, altiplase, anistripase and retiplase. Thrombolytic therapy resolves the thrombi or emboli more quickly and restores more normal hemodynamic functioning of the pulmonary circulation, thereby reducing pulmonary hypertension and improving perfusion oxygenation to the and cardiac output. Contraindications to thrombolytic therapy include cerebrovascular accident within the past 2 months, other active intracranial pressures, active bleeding, surgery within the past 10 days of thrombotic event, recent labor and delivery, trauma or severe hypertension. Before thrombolytic therapy is started, prothrombin time, partial thromboplastin time, hematocrit values and platelet counts are obtained. Heparin is stopped prior to administration of the thrombolytic agent. Surgical management. A surgical embolectomy is performed. Pulmonary embolectomy requires thoracotomy with cardiopulmonary bypass technique. Transvenous catheter embolectomy is a technique in which a victim vacuum cupped catheter is introduced transversely into the affected pulmonary artery. Suction is applied to the end of the embolus and the embolus is aspirated into the cup. Nursing management. Minimizing the risk of pulmonary embolism. It's a role of a nurse to identify patients at high risk of PE and to minimize the risk of PE in all patients. Preventing thrombus formation. The nurse encourages ambulation and active passive leg exercise to prevent venous stasis in patients on bed rest. The nurse instructs the patient to move the legs in the pumping exercise so that the leg muscles can help increase venous flow. Advises the patient not to sit or lie down in the bed for prolonged periods, not to cross legs and not to wear constricting clothing. Intravenous catheters should not be left in place for prolonged periods. Assessing potential for pulmonary embolism. The nurse examines patients who are at risk for developing PE for a positive Homan sign. To test for Homan sign, the patient assumes a supine position, lifts the leg and dorsiflex the foot. Cough pain occurs during this maneuver. The occurrence of pain, a positive sign of Homan sign, may indicate deep vein thrombosis. Monitoring thrombolytic therapy. During thrombolytic infusion, the patient remains on bed rest. Vital signs are assessed every 2 hours and invasive procedures are limited. Tests to determine prothrombin time, partial thromboplastin time are performed 3 to 4 hours after thrombolytic infusion is started to confirm the fibrinolytic system have been activated. Because of the prolonged clotting time, only essential arterial puncture and venipuncture are performed. The manual pressure is applied to the puncture site for at least 30 minutes. Pulse oximetry is used to monitor changes in oxygenation. The nurse immediately discontinues the infusion if uncontrolled bleeding occurs. Managing pain. A semi-fowler's position provides a more comfortable position for breathing. However, it is important to continue to turn the patient frequently and reposition the patient to improve the ventilation perfusion ratio. Nurse administered opioid analgesics as prescribed for severe pain. Managing oxygen therapy. The nurse assesses the patient frequently for signs of hypoxemia and monitor the pulse oximetry values to evaluate the effectiveness of the oxygen therapy. Deep breathing, incentive spirometry are indicated. Or patient prevent atelectasis and improve ventilation. Nebulizer therapy, percussion, postural drainage may be used for management of secretions. Relieving anxiety. Nurse must explain the therapy and describe how to recognize untoward effects early. Monitoring for complications. The nurse must be alert for the potential complication of cardiogenic shock, right ventricular failure. Providing post-operative nursing care. The nurse measures the patient's pulmonary arterial pressure and urinary output. Also assess the insertion site of the arterial catheter for hematoma formation and infection. to prevent peripheral venous stasis and edema of the lower extremities. The nurse elevates the foot of the bed and encourages isometric exercises, use of elastic compression stockings, and walking when the patient is permitted out of bed. Sitting is encouraged because hip flexion compresses the large veins in the legs, promoting home care and community-based care. The nurse instructs the patient about how to prevent recurrence and what signs and symptoms to report immediately. Thank you.